Good afternoon. My name is William Moss, and I'm the Executive Director of the International Vaccine Access Center. And it's my great pleasure to welcome all of you for this 10th anniversary celebration of IVAC. We are very thrilled that you are all here. I am going to give a special shout out to some of our very special guests in the audience, and if I neglect you, I apologize, but I want to acknowledge our Dean, Ellen McKenzie, thank you very much, and our former Dean, Al Sommer, and sitting next to him, Professor Mike Levine, who we're delighted to have here join us, and Professor Ron Dagan, who's visiting us here at IVAC. And so I welcome all of you to this 10th anniversary event. IVAC has changed and evolved over the past decade, and we're going to be talking about that today during today's celebration. But in many ways, IVAC has remained the same. And our mission is a world where people and communities are free from the health, economic, and social consequences of vaccine-preventable diseases. And that's remained our core vision over the past decade. So how does IVAC do this? How does IVAC address this grand ambition? Well, we're a multidisciplinary team that really works together toward a common goal. We have folks working in epidemiology on the burden of disease and the impact of vaccines. We have a team working on the economics and finance of vaccines, showing the value of vaccines, and you're going to hear more about that. We have a policy advocacy and communications team, and this is really one of the core features or components of IVAC, where we translate evidence, rigorous scientific evidence, into policy and into messages that stakeholders and policymakers can use. We also have an operations team that holds all of us together and makes all the nuts and bolts work for all of this. But more than just being a multidisciplinary team, IVAC is very much a family. And I think that's one of the things that makes IVAC so special here within the Bloomberg School of Public Health and within the Department of International Health. We work very closely together across disciplines to achieve our goals. We laugh together, but we also cry together. Rarely, but it happens. And so we're here to really celebrate the successes of IVAC over the past 10 years in generating evidence, turning that into policy, and improving access to vaccines. This is also a time for us to celebrate the tremendous public health value of vaccines. Vaccines have saved millions of lives over the past decade and many decades since they've been introduced. They've been really key in reducing child mortality around the world. But there remain many challenges ahead. Vaccine coverage has stalled over the past decade. We're in the midst of measles resurgence throughout the world. And so what we want to do today is, using IVAC as a lens, consider the successes of vaccines, but also some of the challenges going forward. So our agenda for this afternoon is, after my introductory remarks, we're going to show a short 4-minute video kind of about the history of IVAC and what IVAC is all about. We're going to have 3 brief presentations, about 5 minutes each, from a panel of speakers, what are we going to call lightning rounds, that are really going to highlight some of the fundamental work done at the International Vaccine Access Center. We'll then have our keynote address by Dr. Oren Levine, the founder and first executive director of IVAC, now head of global delivery at the Bill and Melinda Gates Foundation. We're then going to move to a panel discussion where we'll have our 3 speakers, plus Orin, plus one of our famous IVAC alums, Allison Baer, who are going to discuss some key issues related to the current status of vaccines and some of the challenges. And that panel will be moderated by Brian Simpson, the editor-in-chief of Global Health Now. We're then going to have some closing remarks by Professor Mathu Santosham, and we will then have a networking reception with wine and food that you can see out in the gallery. We have a number of kind of images from IVAC. Matt Coles has created some trivia questions for us to address during the networking session, and we welcome you all to join us at that. Before we see the video, I also want to express our deep gratitude to the whole IVAC team that spent many, many weeks putting this event together. And I particularly want to acknowledge Rose Weeks, who's really been spearheading this event. So we'll go now to a brief 4-minute video to give you an introduction to IVAC, and then we'll come back for our lightning rounds.
Okay.
Okay. Yeah. There we go. Thanks.
We know that vaccines are one of the most powerful interventions we have. There's a saying that says vaccines do not save lives, immunization saves lives. So that's in a way the mission of IVAC.
The International Vaccine Access Center at Johns Hopkins is a really interesting center that brings together a really diverse group of professionals: epidemiologists, economists, clinical trialists, policy people, advocacy, communication people who work on problems in the vaccine immunization space to pull together that diverse range of expertise to drive at innovative solutions. IVAC is centered, it lives, it's housed within one of the oldest schools of public health in the world, one of the largest departments of global health in the world, and it is fundamentally committed to using evidence and data to drive its decisions.
IVAC helps generate, synthesize information, translate that evidence to policymakers so that they can make informed decisions about vaccine introduction and strategies for the use of vaccines, and then to bring those vaccines into communities to achieve the access that's needed and to evaluate how that process is working, to measure the access, and to ensure equitable and complete coverage in communities.
In the past, there's never been a center like the IVAC, International Vaccine Access Center, where the goal and the mission and the vision is to make sure there's no child that's left behind.
We're celebrating our 10th anniversary, building upon the work that we've done over the past decade, but there are many challenges ahead. We have challenges with our current vaccines, trying to get increased coverage, for example, with measles and rubella vaccine. But we also have new vaccines with new challenges in expanding access to vaccines such as the rotavirus vaccine, challenges to increasing access and equity for the human papillomavirus vaccine.
Humanitarian crises are increasing, displaced populations are on the move. There's a tremendous increase in urbanization, and especially the urban core.
We measure the economic value of vaccines through our work in the economics and finances of vaccines.
In Bangladesh, for example, one episode of rotavirus can end up in wiping out that family's income for the whole month. So we have a great obligation to make sure we stop the cycle
to bring that evidence into policy through advocacy, through developing communication tools, through developing websites that disseminate accurate information about vaccines, such as ViewHub and Voice.
So those are very big challenges, and there are no simple answers to that. But I think IVAC certainly is in a position they can make a big dent in this issue, and we will fulfill our mission, which is to make sure that every child has access to vaccine, and we will not rest until that happens.
All right. So that hopefully that gives you kind of a feel for IVAC. Actually, next we have a very special guest who could not be with us here today, but who is going to join us by Zoom, and that's Professor Kate O'Brien. And Kate was the second executive director of IVAC, and Shawnee, okay. And Kate left IVAC to become the director of immunization, vaccines, and biologicals at the World Health Organization. And Kate, as with our keynote address speaker, is really one of the foremost global advocates and experts in vaccines. And so Kate very much wished to be here with us. And there she is, and we've asked her to say a few words. So thank you, Kate.
I'm so excited to see all of you. I can't see everybody in the room, but I see Dean McKenzie, Dave Peters, Ron DeGan is in the audience, the Oren, Michael Levine. And then you get a little fuzzier behind you. You are there. So I'm really excited about this anniversary. I have to say, we planned this a couple of years ago when we were trying to remember, in fact, what was the actual date when IVAC was born. And I wanted to just spend really just a couple of minutes on sort of reflections. I was really thinking a lot about IVAC and why it's such a special place. And there are 5 things I wanted to share with you. For those of you who work at IVAC or who collaborated with IVAC, I think these will ring true. And for those of you who are wondering why IVAC is the special place that it is, maybe these will help you understand a little bit. The first is it's a team of all talents. It's a team that welcomes in anybody who can make a contribution to the kind of impact that IVAC wants to have. It's really impact-oriented and has a strong and capable team, but extraordinary and invaluable partners. And it's a generous place. The second is the importance of optimism in overcoming failures. And IVAC, the projects that we've had, the people, we've had both our project-related failures and we've had personal failures and personal challenges. And those have, as a team, we've seen through those difficult times, both in projects and as people, through that optimism as a team. The third point that really came to mind as I was thinking about IVAC is a phrase that I think it came from a commute that Orin and I and Danny Fiken would commute up from Washington on a regular basis. And there were many ideas born in the cars that carried us on that commute, but one of them was about evidence-based courage. And some of the work that we've tried to undertake at IVAC has not been popular work and has certainly been moving against the current of popular opinion or what was felt to be sort of settled opinion on some of the science. And an example of that is the PERCH project, where we tried and succeeded in actually estimating the etiology of pneumonia, which had never been done before. So that confidence that evidence would point us in the right direction, even if the voices around us were saying it couldn't be done. The fourth principle or idea in IVAC that I think has been the source of tremendous energy is I think we've had a commitment to do what sounds like fun and is a little bit terrifying. And that usually involved travel, wild animals, lions, giraffes, waterfalls, mountains, unexpected disruptions, including landing in Gander, Newfoundland, when a team of us were supposed to be on our way to Belgium, and the plane had engine troubles over the mid-Atlantic Ocean. And those shared experiences have certainly seen us through a lot of late nights and challenging work. And probably the most important thing that I learned at IVAC is something that I think Bill Fahey said, which was to recruit people who are too young to know that it can't be done. And I think the students are really what has made IVAC one of the most incredible places to work. The energy, the optimism, the thirst for doing something a little bit terrifying, and still too young to realize that what they're trying to do, nobody thinks they can do, and miraculously they pull it off. So I have to say my time at IVAC has been one of the most extraordinary periods of professional challenge, professional enjoyment, and really seeing how the work that we do with all the partners that we engage with has a really direct impact on the lives of both kids and adults in the communities where that work is taken up and has direct impact. So I'm absolutely delighted that we're celebrating the 10th anniversary of IVAC, and that it was born out of many more years beyond those 10 years of work that led up to the development and birthing of IVAC. And as one of the founding members of IVAC, I couldn't be more thrilled to be celebrating this 10th anniversary and wish I could be there with you. So thanks a lot.
Thank you very much, Kate. It's so wonderful that you could join us remotely. And I am obviously deeply honored and humbled to follow in the footsteps of Oren Levine and Kate OBrien. And my little internal joke is that I can't wait to find out what I do next. All right. What we have next are our lightning rounds. And I just want to say a few words in introduction for the presentations, and then I'll introduce the speakers. But we at IVAC are obviously looking forward. And, what is the next decade of vaccines going to look like? And Kate OBrien is leading in part the global efforts to formulate the Immunization Agenda 2030. What are the challenges of the next decade? And just to lay out some of the things that we're thinking about and working on at IVAC, one is how do we reach the unvaccinated children? I mentioned earlier that vaccine coverage has stagnated at around 85% globally for a number of key childhood vaccines. How do we reach those 15% who are unvaccinated, the so-called zero-dose children? And we're working on a number of ways to try to identify those, one way being serosurveys, and try to vaccinate those children. Another thing in the next decade are going to be adult vaccines and looking at vaccines along the life course. And Lois Perberdum, who's one of our speakers, is kind of leading our effort in thinking about life course vaccines and vaccines for adults. Continuing to establish the return on investment, the economic argument, and the value of vaccines. And we're going to hear from Brian Patnow about that work. But that's going to be increasingly important as resources are stretched, as it gets more and more expensive to reach the unvaccinated children, and as we have new vaccines that have to be supported and financed. We're also going to continue vaccine advocacy and in ways to increase vaccine demand. We're all familiar with vaccine hesitancy and how that has led to low vaccination rates in some countries and with explosive outbreaks. The real tragedy in Samoa right now with the measles outbreak that's resulted in thousands of cases and over 60 deaths. And we're doing that through many of our vaccine advocacy efforts, and you're going to hear Lois talk about the voice tool that really actually expands the value of vaccines beyond the economic benefit into social and development and economic benefits. And we're going to hear from Dr. Chizoba Wande, who has really led efforts to get civil society organizations to promote vaccination, and particularly in Nigeria. So I'll introduce, those are just some of the ways in which IVAC is kind of looking forward and kind of a broad scope of work in the coming years. I want to briefly introduce our three speakers for the lightning rounds, and I'll introduce all three, and then they will come up one by one and give a 5-minute presentation. The first is Brian Pattenout, who is one of our newest members to the IVAC team, but who has been so critical to the economics and finance work at IVAC. And I was so delighted when he agreed to join our team. I remember when David took me into his office and we asked him, would you be willing to work with IVAC? And he immediately said, yes, I want to work on vaccines. And it's been a great pleasure. And he's been so productive leading the Decade of Vaccine Economics work and then taking that into new directions with a recently funded project from the Bill and Melinda Gates Foundation. So Brian is a health economist and a member of our economics and finance team at IVAC. As I said, he kind of led the wrap-up, I'll say, of our Decade of Vaccine Economics work and is moving that forward. Prior to joining IVAC and coming to the school, Brian worked on HIV at the Office of HIV/AIDS at USAID and was their senior health economist. So he's worked in many countries across different diseases, has very broad experience. And I think we all need to give a big shout out to Brian because last week he was selected for, you knew I was going to say this, he was selected as one of the 30 under 30 by Forbes in health policy and healthcare. Our second speaker is Lois Priverdum. And Lois is one of the original IVACers, so she goes way back, even before IVAC was IVAC. Lois is the director of a policy advocacy and communications team at IVAC. And as I mentioned earlier, this is really a core function of IVAC and what distinguishes IVAC from many other academic institutions working on vaccines, and really taking the scientific evidence, converting it into language that's understandable by policymakers and using it for advocacy among vaccine end users and those making the decisions around vaccines. Lois is also, as I mentioned earlier, really spearheading our efforts in life course vaccination and adult vaccines, and is going to take IVAC forward, I think, in that direction. Our third speaker is Dr. Chizoba Wande, who's a physician from Nigeria, and she's the director of Nigeria country director for IVAC. And Chizoba splits her time between Nigeria and Baltimore and really leads our efforts in Nigeria. She has a number of projects there, one looking at use of mHealth tools to increase vaccine demand, and also, as I mentioned, really spearheading efforts to get civil society organizations and particularly women's groups to be key advocates for vaccines. And Nigeria is obviously a key country in terms of the needs for increasing vaccine coverage and preventing child mortality. So I'll invite Brian up to start the lightning rounds.
1 second. All right, thanks, Bill. I'm Brian Patnode. I'm currently the PI on the DOVE project. So DOVE stands for Decade of Vaccine Economics. And we're currently in the 4th iteration of this project. So this study really seeks to quantify the economic benefits of vaccines and what they've been during the decade of vaccines from 2011 to 2020, but also what we predict them to be in the future and what that looks like. So we do this in 2 important ways. One is through this approach called cost of illness, which is basically identifying all of the averted costs that don't happen because we vaccinate someone. So averted payments going for treatment, things like productivity loss and not being able to go to work and the wages you lose out on. So that's one way. And the other is through what's called a value of statistical life approach. I won't get into the technical details, but this is just basically trying to capture the broader social benefits that come along with vaccines by trying to figure out the value that people place on things like happiness and just feeling healthy in their everyday lives. So why is this important? This is particularly important in resource-limited settings as a method for advocating for the benefits of vaccines in a way that's comparable to other things that countries that may not have a lot to invest in. So things like education, things like infrastructure, things like even exports, trying to put everything in a common language so that we have a way to discuss this on level playing field. So as I said, I lead the 4th iteration of the DOVE study currently. And the first iteration began right at the beginning of the decade of vaccines in 2011. And what the first 3 phases of DOVE really did were build these models to measure cost of illness and return on investment and the cost of financing vaccines over the course of the decade. What DOVE 4 currently does is update these models to try and take into account new things that have happened and new data points that are available to determine the return on investment of vaccines, bring this into the prediction landscape so that we can say, what do we think the returns are going to be going forward? And then also dig deeper into a couple areas to understand the methods that are used. So a couple things that we do are, one, predicting the economic benefits for the next decade, but also trying to figure out through primary data what's going on with the cost of illness in countries. Like, what is the true cost that we're averting through vaccinating people? And we do this through field studies in Uganda and Bangladesh. And then we also look to pilot new methods of what we can do to assess how much people value vaccines, the people who actually receive them and use them. So we do this through piloting what's called contingent valuation studies in Bangladesh currently. So now let's get into what these benefits have been and how big this whole thing is and what we found new. So I think a lot of you might be familiar with a 2016 study that came out, which sought to assess the economic benefits midway into the decade of vaccines, which found that the return on investment from a cost of illness perspective was 16 to 1. So for every $1 invested, we are seeing $16 in averted healthcare costs or costs that are returned to the economy. And through broader benefits, this was 44 to 1. So our most recent study, which takes all of this updated data and new methodologies and recalculates what was going on through the decade of vaccines after it's now pretty much completed, finds that we see for 94 countries a return on investment from a cost of illness perspective of 26 to 1 and from VSL 51, so huge returns. And going forward into the next decade, we can assess that these gains are sustained. So long as we achieve the financing and coverage goals that we set out to achieve, we expect, even as costs rise to institute the vaccine programs and introduce new vaccines, we're likely to see sustained high investments in return on investment for vaccines. And focusing on Gavi countries, so just countries that are supported with Gavi vaccines, we find that these numbers are about 21 to 1 and 54 to 1, depending on the approach. So quite large numbers and quite consistent with what we all know as vaccine researchers, that there are huge benefits to be seen from vaccination. So this highlights sort of what we've done and what we've been able to achieve during the decade of vaccine and what we hope to see going forward. And as we come to the end of the decade of vaccines in 2020, the DOVE project winds down to an end. But we're still continuing to do work with the economics and finance team there, and I'll be leading new work going forward that seeks to address some of the outstanding problems in vaccine economics, such as what do we expect to see at the country levels for countries who are either introducing new vaccines or trying to sustain and finance their vaccines internally outside of donor support potentially. And also, what are the equity implications of these investments? Like, what do we see at the country level in terms of how countries that have succeeded in generating high returns on investment do when it comes to comparing different populations and their equitable access and use and realization of these returns? So these are things that we hope to examine going forward in what will be called Project VERSE, Vaccine Economics Research for Sustainability and Equity. So thank you, everyone.
Great. Good afternoon. So Brian gave you a lot of information. It's my job as an advocate to really think about how do you synthesize that information. And let's see. And so we have a new tool that we're very, very excited about. This came from the challenges that some advocates have is that there's little sound bites that they can think of. They could think of how many lives saved vaccines would lead to, or in some cases, even return on investment, because that's something that has been drilled into their heads. But there's a whole array of data out there that nobody has really fully harnessed. So in talking to the advocates, we realized that there is a big unmet need to be able to synthesize the evidence that is available to talk about the broader value of vaccines. Now, one of the things that's really exciting about this particular coming decade is that there's more of a focus on SDGs. And it's not just about SDG 3, it's about all of the other SDGs. So it's about climate change, it's about equity, it's about poverty, a whole number, and there is, I think, about 17 different SDGs that relate to immunization. That's a lot of information for an advocate to be thinking about. So what our team does is it tries to make it more simple, put things in categories, make things accessible online. So you can see up here, this is the cover page of Voice, Value of Immunization, Compendium of Evidence. It's a new tool that synthesizes the data into particular categories, because one of the other rules of advocacy is to think about your audience and think about what they care about. They don't want a whole list of things. They want to be able to synthesize based on what is the topic of the day. Who are we talking to? Is it somebody that cares about poverty? Are they caring about antimicrobial resistance? Is their issue health systems? So take all of that evidence and start to categorize it in a way that you can talk about key concepts. So, if we're talking about equity, for example, gender equity, talk about the idea that there is inequity between girls and boys. Unfortunately, girls are a lot less likely to be able to access care, and that's a problem. But there's opportunities. There's also places where we've had a lot of success. Like, for instance, in Nepal, being able to pull out the evidence that they've been able to take programs where they've targeted pregnant women, that they've given cash incentives, that they've talked about, different programs so they can educate the mothers and really empower them and reduce some of those inequities. In Rwanda, they've been able to take the school-based HPV program and not just offer HPV vaccines. That's a huge benefit in itself. But think about the benefit of really taking advantage of health systems and being able to deliver deworming, being able to deliver health promotion, really building up the primary care concept, talking to other partners. One of the things that we really don't talk enough about is the value that vaccines bring in bringing people together. One of the concepts of advocacy and one of the things that's truly going to bring immunization forward is if we can all work together towards one particular goal. And that's something that immunization has done. In inequity, another topic that I talked about some of the things that we point out is that the problems with the urban poor and how girls in urban settings in India are 22% less likely to be immunized. What that does is that says, okay, that's a big problem. We need to put some resources into those particular areas. And here are some things that you can find through the VOICE tool. The VOICE tool also focuses on feature issues. So we did some on poverty. We've talked about diarrhea. We've talked about the vicious cycle of undernutrition. So it's an opportunity to synthesize the evidence in one place and start to get people thinking, get people looking for evidence and looking for particular topics. So when they go up against what they need, that they're able to make the case. So thank you, and visit VOICE at immunizationevidence.org.
Good afternoon, everyone. I'm Chizoba Wonodi, and I want to tell you the story of WAVA, Women Advocate for Vaccine Access. Let me advance the slide. Can you help me? Okay. So IVAC is about, okay, thank you. Thank you. So IVAC is about taking evidence along the continuum from evidence to action. So WAVA, Women Advocates for Vaccine Access, is operating at the action level, at the access level of that continuum of IVAC. So with IVAC, you get the whole package. So WAVA, the concept of WAVA was thought about in 2016, when we realized that for Nigeria particularly, or earlier than that, there was this huge funding gap that was facing the country as Gavi was set to transition away its support for Nigeria, and the government funding for vaccine was very, very inadequate. So government was budgeting only about 20% of what was needed to vaccinate the 7 million children that were born in Nigeria every year. So we thought that we needed to unleash the power of women. You know what women do when we come together? We can use both our bedroom power as well as our boardroom power to move things. So we brought together women at the high level. So over there, you see the lady in blue. At that time, she was the wife of the Senate president. We also had governors' wives who were champions within the WAVA space. And then we also brought women who were operating at the grassroots level. So we brought together about more than 50 different organizations, women organizations working in a diverse set of developmental areas. So there were some people who were working in health, some people were working in education, some people were working in agriculture. And the idea is that vaccination is for everybody. It's not just for people who work in health. It's not just for the professionals. Because we have to always think about, why are we doing what we're doing? All of us here, we're doing our public health because of the ultimate beneficiary. So in order to bring the decisions very close to the ultimate beneficiary, that child in that hospital, that child in that last mile that requires the vaccine, we needed to galvanize civil society organizations. And that's how WAVA was formed. So how did we operate as WAVA? We did three major things. The first one was evidence. So civil society has a lot of passion. You know, they can convince you about what they want. But for a space like vaccine, because of the risk of hesitancy, we needed to make sure that the advocacy that was being done was evidence-based. So we took data and synthesized them and brought them down to their level so that when they talk, they are talking facts and they are talking credibly. The second thing we did was to empower them. Based on the funding from Gates Foundation, thank you very much, we were able to provide small grants to them. And what that did was it activated them in different areas. We had a group, Vaccine Network for Disease Control, that went to Niger State. And what they did was they identified influential women in the community. And they just simple intervention with them all those influential women, those women now went and started knocking on doors. They knocked on both the household doors, and they also knocked on the political doors, so that at the end of that short project, there was, improvement in uptake of vaccination. They also worked with women in the parliament and saying to them that you are women in the parliament. This is about vaccination. We cannot allow our children to be unprotected because the government is not allocating sufficient funding for vaccines. So we had champions in the parliament. Then the third thing we did was because it's a coalition, so we brought them together and networked them together. So even with simple things like having a WhatsApp group, we can message them when there are opportunities for them to apply for things. We put it on the WhatsApp group, and then they apply for it. So that way, vaccine is top of mind. They have access to resources. They have links to support that can help them improve their advocacy role in vaccination. So that's at the community level. Now, at the policy level within Nigeria, we had things like, we convened high-level meetings where we brought together legislators, and the gentleman in blue over there was the sorry, that was my timer. He was a parliamentarian. He was so passionate about vaccination, and he made it an agenda item in the parliament. Then at the global level, what WAVA did was to apply to be a member of the Gavi CSO Steering Committee. The Gavi CSO Steering Committee is a member of the Gavi constituency, and our role in that constituency is to make sure that all decisions that are made at the global level have been vetted through the lens of the ultimate beneficiary. So if there is a policy that needs to be passed, the CSO constituency sits together and we ask ourselves, how is this policy going to affect people in the community? How is it going to drive equity? How is it going to drive acceptability? And so we serve as a sort of watchdog role to make sure that policies are made with the view of the ultimate beneficiary in mind. So for the next steps in terms of what comes next, we will continue to support the IA 2030 that you mentioned, and then we'll also continue to support decisions that are being made at the global level. So thank you very much.
So I think hopefully that gives you kind of a flavor of the diversity of work that IVAC does, but also the passion about what we do. We work along this continuum of evidence to policy to access, although I'm going to take a clue from Chizobin, maybe call it evidence to policy to action. That's really important. So it's my great pleasure to introduce Dr. Oren Levine, whom many of you know. Orin is head of global delivery at the Bill and Melinda Gates Foundation, and really one of the leaders in the vaccine world globally. He is a deep thinker about vaccines, cares deeply about improving access and reducing morbidity and mortality due to vaccine preventable diseases, and has really been an innovative thinker in vaccines. As I mentioned earlier, Orin was the founder and first executive director of IVAC, and we were thrilled when he has an extremely busy schedule, but we were thrilled when he agreed to come and deliver our keynote address today. Orin also, for the students, Orin received his doctoral degree from this school in the Department of Epidemiology under the mentorship of Professor Ken Nelson. So Orin, it's great to have you here, and thank you so much for taking time out of your busy schedule to join us for this 10th anniversary.
Yeah, I'm not going to have any slides. Thank you. It is really, really it's incredible to be back here. It's great to see so many familiar faces in the video, here in the room. And I think it's a testimony to the cohesion of IVAC that you're all here. Trish, I'm going to ask you to hold me to task. You always were good at that. I'm going to start telling stories and talking about stuff I care about, so I could go on and on. So will you do me a favor? If I start to run on a little bit, will you just put up your hand and say, Oren, stop. Thank you. Some things don't change. So I thought I might start with a couple little stories about how IVAC began. Some of the people in the room here were part of that and remember it pretty well. Because in many ways, IVAC never should have been. Bill mentioned that I graduated from Hopkins Department of Epidemiology in 1994, and I did, and I went to CDC to do a EIS program. And when I left Hopkins, I said, I don't know what I'm going to do after CDC, but one thing I know is I'm not going back to Hopkins. So the first teachable moment, students, be careful what you say when you leave. The second thing is, before I got here, the biggest grant I ever had was $150,000. And then I got this $30 million grant from Gavi, so I didn't deserve that. And then lastly, when I joined here, my wife and I had just had our first child, and we were living in DC, and I was working up here, and I said, don't worry, honey, don't worry, it's not a big deal. It's a 3-year grant. It's only a team of 8 people. It'll be fine. And so that was 2003, and here we are, all the way in 2019. So in some ways, IVAC is born out of these remarkable beginnings with Pneumo ADIP and the HIB initiative, and around 2008, 2009, as those projects were maturing, we were trying to think about what are we going to do next. And the answer to the question I think Kate had is the day that we announced the IVAC Center was December 1st, 2009. So just about exactly 10 years ago. And I remember really well when we were together as a leadership group trying to figure out what we were going to do and how we formed the center. I think it was Maria. We were discussing different things that, Maria Knoll, different things that we could put in grants for. Maria said, I don't really care which thing we work on. I really care that we do it together. And to me, that has always been what IVAC is about. IVAC is about the people. It's about the mission. It's about coming together and working together. And in some ways, it didn't matter what we were working on as long as we were working on it together. I think about that a lot. I think it's been at the center of what's made IVAC a really remarkable and remarkably productive center, but also a place that even 10 years later is still fun to work at. So I really hope that all of you will cherish that. Put some glasses here. Didn't have to need these. Yeah, I'm tempted to tell stories because there's so many people in this room that I want to tell stories about. But I guess more to the point, I would say that the story of IVAC is also a story of a group with a little bit of attitude, but in a really good way. In a really good way. Maybe occasionally challenging for the administration, but in overall a good way. A good way in the sense that I think the spirit of IVAC has always been not to be satisfied with status quo, whether that's in the rigor that we apply to trying to measure something or go about the analysis of the data, but also not satisfied with just knowing that there's a number or an answer, but that drive to action. And so in many ways, the scholarship of IVAC has contributed to the global immunization field in so many different ways. Documenting disease burden, understanding attitudes and perceptions and how we shape those, but also by using data for influence. And I think it's it's the contributions of both the rigorous kind of scholar and the communication and advocacy put together that has been really, really useful. And I think, as I think back on my advocacy and communications colleagues here, I think they really taught us the value of stories too. I remember in, I might need help here, but I think it's going to be around 2006. Maybe 2008, we sent a photojournalist on a tour to Africa and Latin America to develop stories about immunizations. We had all the data, but we realized there's a human element to that data as well that we were missing. And I still remember the story of this woman, Tiamani Diarra. There's an incredible photo by photojournalist Adrian Brooks of Tiamani Diarra in the main hospital in Bamako, Mali, with her head in her hands. She just lost her second kid from pneumococcal disease. 2 daughters, both died in the same ward a year apart. And what got me is that those kids were daughters like mine, born almost at exactly the same time as mine, but they didn't live in a country that had pneumococcal disease, a pneumococcal vaccine, and they died in the same hospital just a year apart. And we did a lot of work as IVAC to understand the economics and the return on investment and all that kind of stuff. But I think the partnership with our advocacy and colleagues, friends, also reminded us that there's a human element to vaccines and immunization, and we need to be prepared to tell that as well. So I want to shift a little bit from celebrating the past of IVAC to also speak to a little bit to the future. And I'll try to be slightly provocative and challenge us, because I think there's a lot to look forward to in the future with global immunizations, and some really important challenges that we're going to face. The first thing I want to talk about is inequality. We are arguably living in the best world that we have ever seen. Fewer children die before the age of 5 years old. Fewer people live on $1 a day. Lots of incredible progress. And yet, inequality is rising. And I don't want to get all Bernie Sanders on you, but we all know this, right? That the concentration of wealth in the top 1% is disproportionate. And inequality appears in many different ways. Gender inequality, right? And it occurs here, it occurs abroad. It's a pay gap here. I think in academic medicine, something like 50% of the medical students are female, but only 16% of the deans. You can pick a different way of demonstrating this if you want, but these inequalities are all around us. And somehow we're going to have to confront the fact that we are living in the best world that's ever been, and we have rising inequality. Second, I want to talk about trust. This is probably the most essential ingredient for successful health systems, and yet it's in decline. When you think about what's contributing to that decline, well, certainly declaring everything as fake news does not help. But there's a number of things that contribute to that, and not all of them are just the fake news declarations. It's true that there are individuals who go to Google University and inform themselves, and sometimes that helps by giving us, empowered citizenry, and sometimes it leads them to misinformation that amplifies things. But there have also been spectacular intentional betrayals of trust. We need to own the fact that when the CIA used as a ruse a hepatitis B campaign to try to find Osama bin Laden, they fueled mistrust by that. In China, when there was a failure to adequately address the quality of vaccines, that led to parents actually protesting. That's a legitimate breakdown in trust. There are also examples of our own health system's failures in the field that contribute to that. Consider that over 900 people in Pakistan have been infected with HIV through the reuse of syringes and needles. Over 700 of them are kids. That would make me hesitant to trust my health system. And in immunizations itself, we have errors that contribute to trust. Just over a year ago in Samoa, unintentionally, nurses reconstituted freeze-dried measles vaccine with muscle relaxants, and 2 kids died. All of these contribute to distrust. That distrust is not just at an individual level, it's also expressing itself in our coalitions and organizations. For those of you who've been following the news, NATO, which has been a bedrock alliance for however many years, is in flux. If you look at trust in the United Nations, it's still strong in many countries around the world, but it's declining in the US, and we have a partisan gap in that trust that has been growing over time. And then lastly, there's a trend to disruption through tech that we need to acknowledge. Global mobile technology is advancing everywhere, and with it, many positive features and also disruptions. Disruptions that we can either capitalize on or be negatively impacted by. I like to think about some of the really positive disruptions out of that. I was lucky earlier this year to be in Rwanda and see a really exciting application of telemedicine there through a company called Babel that was basically providing routine primary health care to clients in a health center, but instead of them spending hours to get that health care, they were getting the health care that they wanted in under an hour. And so there's really great opportunities there for us to be able to capitalize. There are also the challenges represented by Facebook and misinformation. So what are some of the opportunities for us, or some of the things that we can do about this? Well, first of all, we can focus on reducing inequalities. We can make this central to what we do in global immunizations, and that's going to be different than in the past. In the past, we've typically defined success as we vaccinated 80% of kids, and good for us. Focusing on inequalities means focusing on the last people in the community. It's not enough to be satisfied with 80 or 90%, but actually focusing on the last people and the left out communities. And what that means is a focus on subnational data on coverage and disease incidence. It starts with not being satisfied anymore with single national average or even a state average. I did a little experiment on my phone. You can do it yourself. If you go to Google and type in Maryland state immunization coverage, the top hit is the Governor's Office for Children. The Governor's Office for Children states that the immunization coverage in Maryland was 77.8% in 2014. And that's based on a survey. We can do so much better than 5-year-old data on a state level. We should be demanding up-to-date data down to the enumeration area. We should be then applying that to figure out what do we need to do, what are the systems failures that are keeping people from getting immunized in those places. Making everyone visible, making that subnational data the focus of action is really important to these inequities getting reduced. Secondly, and this is particularly an issue, I think, for us globally, is I think we're going to have to increasingly integrate our efforts. I think that the vertical approach to immunization has taken us a very, very long way. And it may be that the ceilings that we're starting to hit at the 80% level are a function of the fact that we are not integrating and providing the comprehensive service delivery that communities want and deserve. So there's an opportunity for us to use immunization as one of those tracers to find those inequities and to start a dialogue with those communities to understand what is it that you want designed into your healthcare? What's the package that's essential that includes immunization and more that may break us through the ceilings that we've been hitting? Third, I think we can work on developing new alliances and engaging different partners. I know a lot of people are focused on vaccine hesitancy and the refusals. And a lot of people are bravely championing the cause as vaccine experts. But in a world where people are increasingly distrusting experts, that's not going to be the solution. We're going to have to find the people that resonate as the givers of those message with those communities. Continuing to come back and say, "Hi, I'm an expert and I'm here to help," is going to have a limit in its impactfulness going forward, as much as we wish it were otherwise. And then lastly, I think one of the things that's really exciting as an opportunity for us that brings together this opportunity to be equity focused, to harness technology, et cetera, is to start to move from description to prediction. We should not be surprised when there's a measles epidemic in 2020. Measles epidemics occur when susceptibles build up and the infection arrives. But right now, we react to the outbreak of disease. What we could be doing is reacting to the outbreak of susceptibility. We could be developing data that predicts these are the high-risk communities and moving in there to understand what can we do ahead of an outbreak to prevent it. And I think when we start to do that, we're going to start to re-engage with the value of healthcare and health systems that people want and deserve in a new way and in a more impactful way. But it's going to require us to question some of the things that we've been comfortable with and to begin thinking about doing things in a new way. There's no denying that the future's got a lot of possibilities to it and some real challenges that we're going to have to face. It's going to need lots and lots of people to make that future great. And I'm confident that IVAC is going to be one of those. For the past 10 years, you have innovated, you've driven evidence, you've driven beyond evidence into action, and we're going to need you to keep doing it. And more than that, you've had fun doing it. You're 10 years old. 10-year-olds have fun. Keep doing it. Keep having fun. Thank you, IVAC.
Thank you very much, Orin, for providing that history of IVAC and then kind of the vision for vaccines going forward. And maybe during the reception, you can tell some of your stories. All right. I'm going to invite the panelists up, and we're going to spend about just a half hour having a moderated panel, and we'll be able to take a few questions perhaps at the end from the audience, and that will be our last kind of major feature of this event. So the panelists can come up, and I'm going to introduce you. So I've introduced 4 of them, and I'm going to introduce one new, and then I'll introduce the moderator. So I'd like to introduce Allison Baer, who's taking a seat next to Orin. And as I mentioned, Allison is an alum of IVAC, And I knew Allison, maybe that was HIB Initiative days, I think, as one of the precursors of IVAC. Orin mentioned the HIB Initiative and Pneumo ADAP as the precursors of IVAC. And Allison is currently vice president of the health programs at Lutheran World Relief and IMA World Health. And Allison has worked in many countries throughout Africa, Asia, Middle East. Over the past 2 decades, she's worked with multiple different partners and really brings a broad perspective to vaccines and global public health. So thank you, Allison, for joining us on the panel. And then lastly, I'm going to introduce our moderator, Brian Simpson, who many of you know. Brian is the editor-in-chief of Global Health Now. And if you are not already subscribed to Global Health Now, I strongly urge you to do it. And Brian is also the editor of the Hopkins Bloomberg Public Health magazine. And so Brian's going to moderate our panel. It's going to be a relatively brief panel, and we want to generate some kind of new ideas and discussions, and then perhaps we'll have time for a few questions from the audience. So Brian, I'll let you take the podium.
Thank you, Bill. I really appreciate it. It's a great honor to be here and be part of this. And Bill did impress upon me to keep it really brief, that everybody's been introduced. There's no need for any kind of an introduction. And I had all ready to do my pitch for Global Health Now, even so, but Bill did it for me. Thank you. The only thing I would add is you can sign up for free at globalhealthnow.org. Okay, so let's go ahead and jump right into the questions. So what we're going to do today is divide this panel into 2 in terms of looking at the current situation and then looking at the future. So basically, you've done sort of a lightning round of presentations. I'm going to ask our panelists to do a lightning round of Q&A. So if we can keep our answers brief, we'll be able to get through more things and then have time for maybe a couple questions from the audience right at the end. So Lois, I'm going to start with you. Everyone in this room has not only benefited from vaccines, but has also absolutely believes in the power of vaccines. Now, not everybody outside this room believes that, and in fact that there are anti-vaccine campaigns underway right now. So my question to you is, what's the most effective response to these kind of campaigns?
So thanks for that question, because it's something that concerns a lot of different people. And first thing I want to say is, the true anti-vaxxers or vaccine deniers are a really, really small percentage of the population. There are people that are hesitant, but we're talking about people that are at the end of the spectrum, that are denying science generally. So there is an approach that you can take, and it's a relatively simple approach. You want to first identify what is the issue, what is the topic that you're talking about. You also want to talk about what is the technique that this person is using. Are they trying to spread conspiracy theories? Are they trying to, perpetuate fake news? Are they trying to be very selective in their data? Because those are the things that you want to call out. So when you develop your response, you want to be able to address the question at hand, and remember that your target is not the vaccine denier. Your target is the general public. And we're talking about places where you are in a public forum and you don't have the option of simply ignoring them. So the first choice is, if somebody is throwing out ridiculous things and you have the opportunity to just ignore them, do that. That helps increase your credibility. You don't want to give them a platform. But there are times when, whether you like it or not, there is going to be a debate. So, engage in that debate as little as possible. Don't make it a debate. Talk about the points that you want to get across. You also want to call out the person for what they are and what they're doing, and then develop your response. And remember, the thing that people are going to remember is the things that you're going to say. So don't repeat what the anti-vaxxer just said. Make sure that you get that point across.
That's great. Thank you, Lois. Chizoba, you're up next. I'm going to ask you a question now about vaccine coverage and low vaccination coverage in sub-Saharan Africa. Curious from your point of view, what are some of the reasons for that, and then what are some of the most successful models for responding to that?
Right. So sub-Saharan Africa, is made up of several countries, and on average, the Penta 3 coverage is 72%. But, like Orin said, we need to go more granular, because if you look at country by country, the list is 25%, and the highest is 99%, Seychelles. So the response to low coverage will depend on the country where we're looking at. So if a country like, I believe that country is, I'm not sure the country with 25%, but if a country has 25%, it means that by and large, vaccines are not getting to the facilities and they're not getting to the community. So it's mostly a supply side challenge. And so you need to ensure that first of all, that you have the vaccines. In Nigeria has just come out of a period where we had really low coverage. Coverage is still low. 2016, the coverage was 33%. And one of the major things that was happening at that point in time was that the vaccines were not there. So you have vaccine stock out. So you have to ensure that the supply is there. The funding is there to ensure the supply. Then the second thing you have to do is that you have to really have the governance structure and the sort of the health system structure. For the most part, we've really been looking at a siloed or vertical response in immunization, but we need to look more broadly at how do we strengthen the primary healthcare system as a whole to have resilient systems that can deliver the services. And what we found from Nigeria is that when the government takes responsibility and takes charge of bringing all the partners together, of making sure that we have one coordination platform, making sure that we have one plan, and making sure that we drive delivery from the national level right down to the state and to the health facility level, that it's more effective. So in Nigeria, one thing that has been put in place in the last 2 years is what we call the National Emergency Routine Immunization Coordinating Center. It takes from the idea that was used in the polio response, where you have like a command and control structure that identifies what needs to happen and make sure you drive it right down from the national level to the front lines. So we need strong government systems in place in order for you to make those in order for you to deliver the vaccines in the first place. So you have to take it sequentially. Make sure make sure the services are there. Once you've achieved that, then you can now think about other things like demand, right? So it's a complex thing, and the long and short answer is that you need to identify what the major barriers are in a particular country, address those barriers, use targeted approaches to address those barriers before you move on, essentially.
Great. Thank you, Chizoba. Orin, this one's for you. I know that early on in your work at IVAC, you were, I would say, angered by the disparity between the rollout of vaccines in resource-rich countries and then the time it actually took for them to roll out in low and middle income countries. And I believe you pointed out to me in an interview at the time that there was like a 15-year disparity between the rollout of the Hib vaccine. So what's the current status of that? What would you say are some successes and still some remaining challenges?
Great. Thanks for that. Yeah, I don't know that angry, but highly motivated,
Okay.
and struck by the injustice, which I think gets at the Tiamani DR story that I was telling earlier. And I think actually, if you look back at the last 20 years, one of the great successes of Gavi is that we have fundamentally changed that inequity. We now launch vaccines simultaneously in the poorest countries and the richest countries of the world. We have addressed that inequity. The remaining inequity that we need to work against is the subnational inequity. Take Nigeria as an example. You have parts of Nigeria with very high immunization coverage of 70% or higher. And you have parts of Nigeria, states in Nigeria, with 5% immunization coverage. So those kinds of inequities need to be addressed one by one by one. And it's not even at the state level, it's below that again. So to me, the success with Gavi proves that when we set our minds to addressing inequities, we can. We just need to apply that now to a more focal distribution and the national inequities. Before I give up the microphone, can I just ask how many people in here were ever a student working at IVAC? Can I see hands that go up? Nice.
Not as a student.
Good. You didn't work as a student? No, you did. You did there. Wow, incredible. Great to see.
Thank you. Thanks, Orin. Allison, you're up next, and I will remind our panelists of the lightning round nature of the Q&A here. Not sure we hit lightning there, but there were a few sparks nonetheless. So Allison, you work with a humanitarian organization, and obviously the initial needs are water, food, shelter. Where do vaccines fit in that, in terms of especially a population that you're looking at in terms of a dynamic refugee population?
A very complex question, not a lot of time to answer, so let me take my best stab. So I think the nature of what forced displacement looks like in the world is changing. I think for many of you out there, you're thinking of refugees, you think of the white UNHCR tent cities and MSF or some other external humanitarian organization coming in and setting up basic service delivery for a group of displaced people until they can return home. But I think it's far more common in today's world to see displacement that looks very different from that. You have populations that were in fragile settings to begin with, moving and being absorbed into host communities that are also fragile. And so delivering vaccines to those populations really relies on the strength of the health system that is there in that host community at the time that the refugees or displaced people are absorbed. And so I think this really comes back to a health systems issue. We have 1.8 billion people living in fragile contexts in the world today, along with 80 million forcibly displaced people. And the inequity that exists in the world today is really driven by the service provision to that group of the global population. And that's where you find the majority of the undervaccinated population in the world today. So I would say in order to strengthen vaccine service provision to that part of the population, whether they be forcibly displaced or the communities hosting forcibly displaced, we need to work to strengthen the health systems and the state's ability to provide basic health service delivery, a comprehensive primary care package to those populations, including routine immunization, which is often the foundation on which other services are provided.
Great. Okay. Thank you. Thank you very much. All right, Brian, you're the last one for our current situation question. So you spoke earlier of an ROI of 51 to 1, pretty astounding numbers. Is that enough when you're trying to persuade a country government with low resources or limited resources? Is that enough to persuade them? And if not, what do you do?
Yeah, so it's definitely not enough by itself. So, I mean, widespread popular and professional support and vocal support is probably the most influential thing when it comes to governments. But one nice thing about the ROI, and particularly being able to break it down, so you saw 51 to 1, 21 to 1, but being able to talk about the different levels that ROI occurs at and who that generates benefits to is usually pretty important, because I think when people see health investments in a lot of situations, they see costs and they're not necessarily aware of the full breadth of returns that exist and how those are visualized. So not just that there's averted costs that we're not incurring because we're investing in public health or vaccines specifically, which are seen on paper and on the Ministry of Finance and Ministry of Health budgets, but also that healthier populations are more productive. You can generate higher tax returns, like all of these other things that you can see tangibly in the economy, and really demonstrating and pinning those to vaccines is very important, and I think gets people interested, particularly those who hold purse strings.
Mm-hmm. And do they buy that argument? Those other things?
Sometimes it depends on who you have in the room.
Yeah.
You need a very good advocate.
Yeah.
Right, exactly. Okay, all right, thank you guys. So that was for our current situation. We're moving to the future now. And since y'all did such a great job with the lightning responses, I want to invite you to to jump in and comment on each other's comments. As long as everybody keeps everything brief, we'll be cool with that. And Orin, I'm going to go ahead and start with you. Oh, and I was going to add too that the magic word is disagree. So if we can hear from somebody who says, I disagree, that will be awesome. Okay. So Orin, I'm going to start with you. So one of the thoughts that I've heard is for the future in terms of vaccines is that vaccines will be more geographically focused, more targeting emerging infectious diseases. And that presents an obvious problem, right? Because these are no longer globally relevant vaccines that have a larger market and all of that. So given that, do you agree that that's sort of the future? And if so, what's the answer to that?
So yes, at the risk of not disagreeing, I agree with the statement that we're going to increasingly have globally focused vaccines, and I think climate change is going to exacerbate that. You're going to see hotspots of disease emerge as climate change changes different patterns around the world. I have one hope for how we can manage that, which is I think disruption in manufacturing could be one of the ways that we disrupt this. Imagine if one of our RNA or DNA-based technologies became available so that you could basically identify a new disease that needed a vaccine and then stamp out essentially the sequence that was needed to try and elicit the immune response and tailor that in a very specific way. Maybe we wouldn't need the big global plants that we have today, and we'd be able to manufacture and tailor to different solutions. Just trying to be provocative.
Okay, all right. Anybody want to take that on, or nope? Okay, all right. So Lois,
That's a tough one.
wait, do we get something over there?
Well, I don't know. I mean, Oren knows I come from a manufacturer, and from that experience, it is traditionally tough to maintain costs when you don't have economies of scale. So I think we need to be very creative about how we address that problem. It may or may not work. And I think, part of one of the things that we need to understand is oftentimes it's not the vaccine cost itself that's the issue. It's the cost of development, the cost of R&D. And those are things that we need to be thinking about. How do we make studies more efficient, or the whole process different? And if we could get there, I think we can solve some of those issues.
Great, thank you. And Lois, since you spoke up, I'm going to punish you by asking another question. So what is the life course approach to vaccines, and how do you see that as shaping the future?
Yeah, so life course is simply giving immunization at all stages of life. Traditionally, we've thought of immunization as a thing for just childhood, but there are different risks coming at different points in time. And I think the other thing to also think about is sometimes you're thinking about an individual benefit, and sometimes you're thinking about the societal benefit. You're not always just protecting yourself. You might be a pregnant woman that's thinking about protection of her newborn child, or you want to ensure that you're not spreading disease when you don't need to be, because there's a lot of people out there that can't be immunized. So those concepts are really important. And I think the shift has to be about not just looking at that individual benefit and individual need at the particular time, or individual disease. I think we need to be thinking more broadly, because like for instance with flu vaccine, it's not just about you not having to stay home and have this terrible episode of disease. It's about what is the cost of the health system? What if you have underlying conditions that may be exacerbated? What are some of the longer term effects as we age? Unfortunately, our immune systems begin to decline. So, does that accelerate some of the risks that may happen, and some of the things that you maybe could have done in the past and can't do now? That doesn't just have impact on that single person. that has impact on their family because nobody is going to leave their parents to fend for themselves. And that has impact on, their children and their grandchildren, et cetera. So we need to be thinking about the broader costs of immunization.
Okay, great. Yes,
Can I add
Allison?
to that? I
Absolutely.
think that it's part of this whole issue of the life course approach is part of a much larger conversation that we're going to have to address as a part of the Sustainable Development Goals, which is we have health systems that we've spent the last 60 to 70 years building that are built for maternal child survival and family planning provision. And so there are very specific touch points with the population that are attuned to the needs of the population to address those specific services. And so for anything that we're looking, as the epidemiology of disease changes worldwide, and we're looking at chronic disease or adult vaccinations, we're going to be challenged to be able to reach the population at those new touch points because the systems aren't built for purpose if that is their evolving purpose.
Mm-hmm. Great. Brian or Orin, Chizoba, anybody want to weigh in on sort of that life course approach?
I think the other thing to add is that for developing countries that are going through the epidemiological transition, you're having people live longer in developing countries. So you have a large aging population, and so that's a population that will require, vaccination, be it for pneumococcal disease or things like that. So, and those are the countries where the health system has really been focused on maternal and child health services. So we would need to, expand and make sure we have the systems to be able to reach those people. Mm-hmm. And then the other thing is that a lot of the health funding for the health systems come from donors, right, in these countries. So do donors have appetite to fund programs that are targeted at adults? And then secondly, do the governments have the sort of foresight and everything to expand funding to support programs that will address adults? And that's where UHC comes in,
Right.
Financial risk protection comes in for health expenditures.
Well, I don't think we have a government representative here, but if we only had a donor representative here. Oren, do you want to weigh in?
Yes, I do. So I do want to say that I think donors are part of the problem here. I think that when you pay for a clinic to keep somebody alive on HIV treatment but refuse to pay for their hypertension management, that's kind of silly. And we need to just confront that. But I also think we need to remember that most health actually, you take care of your health outside of the healthcare system as well. So part of managing the life course is just meeting people where they are and designing in the flexibility to be able to do that. And that's a combination of both the agility of a health system and also technology. I mean, if we could, we go and get immunizations now at Walgreens, which we didn't when I was a kid, right? We've pushed it out to different places. And if we had, microneedle patches that were easy to apply and thermostable, maybe it would just be one of those things that I just go on my own as I get a little bit older and I put it on and I'm done. And so I think there's a bright future for the life course approach that's a combination of both capitalizing on technology and designing our systems to be more flexible, provided the donors don't get in the way.
And is the Gates Foundation working on a life course strategy right now?
No, not really. Not by that
it's
name,
in the future.
anyways.
Okay. Maybe in the near future. All right, Allison. So you made some great points about sort of in humanitarian situations right now. Obviously, it doesn't seem to be in the future there's going to be any reason to think that the number of internally displaced people, refugees, migrants is going to be reduced anytime soon. Are there special challenges as you think about the future in terms of scaling up or being better prepared, perhaps?
I did write down 3 points that I wanted to make, but I think Oren actually just touched on most of them. So I don't know if he was reading my notes or... So I think when it comes to vaccines, there are a few challenges that we're going to have moving forward. We have them now, but I think we are rapidly getting to the point where we have the technology or the other sort of ways to solve them. I think one is we need to keep looking at heat stability, because especially when it comes to trying to reach fragile populations living in fragile settings or who are forcibly displaced, kind of by definition, they tend to be in places that are not that the cold chain is not built out to service. And so the more heat stable the vaccine supply is, the easier it's going to be able to deliver vaccine services to those populations. The second is around self-care or task shifting, right? Maybe taking a page from the family planning playbook and looking at vaccine formulations and sort of systems that are built to shift the role of vaccine delivery down to healthcare providers who are working closer and have more contact with the population. And then my third comment would be looking for vaccines that can provide good protection with fewer contacts with the health system. So that could either be more kind of polyvalent vaccines, or it could be vaccines that with a single dose provide effective protection, looking at different ways that we can provide, especially as we get more vaccines into the routine pipeline, the kind of protection we're looking for with the fewest service contacts needed. So those would be my 3 challenges.
Awesome. Thank you, Allison. Chizoba. Oh, Lois, you want to jump in? As long as you keep it under a minute.
Yeah, just the other thing that I wanted to add is in those situations, it's also more imperative to take a human-centered approach, really understand the other stresses that they face. I mean, to Allison's point, you don't want them having to, go to have additional responsibility on what they already have. They're in complex situations. And it's crucial that we not just assume that we understand the needs of one person are the same as the needs of the next person in that situation. And so taking that human-centered approach is essential.
Okay, awesome. Thank you. And Chizoba and Brian, we've got a couple minutes left, so I'm going to ask you to do sort of the brief answers, and we'll still have time for a couple questions from the audience. So Chizoba, Gavi supports low to moderate, low income countries in terms of low resource countries in terms of vaccination programs, but that stops as they transition to becoming middle income countries. How can this challenge be navigated successfully for the middle income countries?
Okay, I think there are a number of ways, and there are some concepts that have really bubbled up in, as we think about transition. One of them is domestic financing, domestic resource mobilization, and innovative financing. If I take Nigeria as an example, when Nigeria was set to graduate from Gavi without adequate preparation, the advocacy that I described earlier on and work that so many other people did set up in motion some critical questions where the government had to ask themselves those questions. What are we going to do when Gavi leaves, right? And what I find from the Nigerian example is that if there is a will, if you take the conversation high enough on the political arena or agenda, you can find a way. So Gavi and partners were able to get the government of Nigeria to make commitments, financial commitments, on how they were going to ramp up domestic financing for vaccines. So there is a paper that states that the government is going to take X amount of funding from this line budget, from first line charge. They're going to take this amount of money from this particular budget. So the planning for transition has to be something that is done at a very high level, that has the commitment of the ministries of finance, the commitment of the presidency, the commitment of the ministries of health. So it is a full country planning for transition, particularly if the support that has been coming for vaccination has really been more than what the country has been providing. So,
And this
like,
obviously would require like years of planning in advance, knowing this is coming.
yes.
That's the other point. I'm gonna have to stop there with you and move right on to Brian. So Brian, you made a great case for the ROI on current vaccines. Obviously, new vaccines will be coming down the pike. How do you go back and make that argument to country governments, to ministries of health and finance, that these new vaccines will be worth investing in?
Yeah, so ROI for those new vaccines can help. But I think another thing that's really important is emphasizing how vaccines contribute to other health system goals that you might have and integrate into those. And that can be done both financially and otherwise. But kind of showcasing how investing in new vaccines and creating the systems that integrate those new vaccines into the delivery of other services and other preventative measures can really strengthen and improve efficiencies in the overall health system is something really important to highlight. And we're starting to see that with HPV in a lot of countries, integrating that with the delivery of other services and how that can save both time and money throughout the system and improve results on a number of different levels, not just things that are directly pegged to the vaccine. Super important.
Okay, all right. Thank you, Brian. I'm going to check with Rose right now. Rose, do we have enough time for a couple questions? And now I'm going to check with Bill.
Maybe one or two from the audience?
One or two from the audience, and we have mics on either side. So if we have one quick question. Yes, right here. Oops. Ruth Karen?
Do you want me to just shout?
There it is.
So I just wanted to congratulate everyone on this, on the wonderful presentations and the wonderful discussion. So I wanted to turn back to issues around supply, and not just supply within a country, but global supply. So I agree with you, Oren, that things like nucleic acid vaccines have great future promise, but really future. And right now we've had critical shortages of inactivated polio vaccine, we're facing critical shortages of yellow fever vaccine and human papillomavirus vaccine, which is probably the most effective vaccine in our armamentarium. So how do we anticipate these shortfalls and work with either existing manufacturers or developing country vaccine manufacturers to ameliorate this?
I think it was, I wasn't there, but I was told that when DA was asked, what's the next thing you want to eradicate after smallpox? He said bad management. And in many ways, the IPV and yellow fever problems are bad planning. And yellow fever, by the way, is in a much better situation this year than it has been in the past. We did have a very serious problem, but that gap has gotten smaller. HPV is a failure. What I want to know is when Merck decided how big a plant to build for HPV vaccine, how many women were in the room. Are they surprised to find out how many women have cervixes around the world? I mean, it just was not capacity big enough at the start for the demand and need, and we need to do better on that.
Fantastic. Lois, briefly.
I don't disagree that we need to do better, but we also need to make sure that we take responsibility for all of us. And, so it's not just the manufacturer's problem, it's also the problem of making sure that and this is the story of the new MOADIP, making sure that we're telling people how are we going to do it? How are we going to ensure that if we produce these, that there will be a market for that? Where is the financing for all of this, and where is the whole plan? So it's not just a single group's responsibility. I think it's a collective responsibility.
Okay, and we've got one last question right over here, and I'll ask for a brief question and brief answers too.
What are some new technologies or systems that you're either especially excited about or especially skeptical of?
Ebola vaccine. I'm excited about it. My organization is very involved in the Ebola outbreak in Eastern DRC right now, and to watch that vaccine be used in that outbreak and to have it be so efficacious, I think is really exciting. I'm really excited that we should never have another outbreak of this size again, and to me that's very exciting.
skeptical about thermostability. We've got, sorry, disagreeing. We've got innovative cold chain technology that is rolling out around the world that's sort of mind blowing. We've got thermoses that can keep vaccines cold for 6 weeks with ice. Just needs to be resupplied. And if you've not seen Zipline drop on time, just in time delivery of essential health products, it's mind blowing. So I actually think that we have more promise in redesigning systems and using cold chain than trying to find a thermostable platform that will work for every vaccine that we need.
Okay. One last brief answer there.
If the supply is available, I'm really excited about the HPV vaccine that prevents cancer. Can't get better than that.
Awesome. All right. Does anybody, you want to go ahead? Okay, we'll go down the line, but it's got to be quick. Anything else?
Do you want to?
Nope. Okay, great. All right. Well, please thank the panelists for, please join me. Thank you. Okay. And I'm going to turn things over to Bill. Thank you.
Great, thank you, Brian. And the panelists are welcome to take a seat, or you can remain there. We're at the end of our session. I know we're a little bit over, and the reception's waiting outside. The wine's getting warm or cold, depending on which wine you drink. But so we're at the time for closing remarks, and it's my great pleasure to introduce a very special person, both to me personally and to IVAC, and that's Professor Mathu Santosham. And Mathu has been an advisor, a mentor, a friend, a colleague, collaborator to many of us at IVAC, and to me personally throughout my time here at the Johns Hopkins Bloomberg School of Public Health. And I'm going to ask Mathu to say a few closing remarks, and he has a very special announcement to make.
Thank you very much, Bill. I was told about 5 times, Mathu, we are happy to have you give very brief remarks. I think they took more than 5 minutes to tell me that. But I am so excited about today. I'm so proud of IVAC. I wish I could take more credit for its success, but there is one credit that I will take. I had the pleasure of actually recruiting Oren Levine. I had the pleasure of mentoring OBrien, and I had the great pleasure of mentoring Bill Moss. Talking about stories, I will tell one story about Oren. When Oren, I think he was at NIH, is that correct, at that time? He came to me and he said he wants to do this advocacy, which all sounded so crazy to me. Didn't make any sense to me at all. But anyway, you know, Oren, he manages to convince you. Then I had the task of convincing Al Sommer. And he said, you want to do what? But okay, I managed to use some of the one-liners from Oren, managed to convince him. And then Al says, Mathu, but just remember, no more space. Don't come back to me tomorrow. You recruited this guy and you want more space. So I called Oren back and said, Oren, I think I can get you a job, but space is a big problem. Oren says, that's not a problem. And then I said, okay, then come back with a solution. And he says, can I walk around your office? In about 5 minutes, he's back with a plan, with a floor plan, where half my people will be moved upstairs next to my office, and he'll occupy the rest. So you have to be very careful when you recruit people. So with that, I really will. This has been so wonderful. I think we need time to get out there, get some wine, and drink and celebrate. And hopefully I'll give you one more cause to celebrate today. I was actually given some notes. I'm going to skip through most of them. I'm just going to say we are in a very exciting period in our life. For some of us old-timers here, I won't point them out to you. They're sitting around. When we started our careers, there were 20 million deaths each year. Now there are 5 million deaths. I think many of you may have read the book, The Tale of Two Cities. It's the best of times, it's the worst of times. But there are 5 million deaths. A lot of children dying. We've had 116 million children vaccinated in 2018. That's an amazing feat. It's never been done before. Africa's child death now is the same as it was in Europe in 1950. That's the positive side of it. The negative side of it is Africa is 50 years behind Europe. So the good things and bad things that are happening right now, many challenges. IVAC has played a major role in reducing vaccine preventable disease deaths, but there's still 1.5 million deaths each year, 4,000 a day. So the work for IVAC is not finished. We have a lot more to do. I will not dwell on this demographic transition that Lois talked about. The fastest moving increasing age group, 65 and older. I just came back from India. You go around asking people, any adult, have you received any vaccines? These are not poor people. These are educated, high-income people. They have not received any adult vaccines. I think we are in a very exciting period in public health. When we went around, when Allison and Orin and Lois, we were all together with a HIB initiative. At that time, everybody thinks if you throw money at a problem, it'll go away. Money was not our problem. We had vaccine supply. Gabby said, we have this great vaccine, come and get it. There were no takers. That's why the HIB program was started, and then it took us another 5 years to get the vaccine into most of the Gavi-eligible countries, and now we've got it all over the world. So exciting things are happening. I just came back from India, and so did Orin, home of 20% of all the deaths in the world. Under 5 mortality in India was 111 in 1990. In 2018, it was 39. Yet, they did not reach the MDG goal for maternal child health. We need to fix that problem. And to that end, I'm delighted to announce that we are now starting a program, which I have to look at the title because it's a long title. It's the establishment of the Child Health and Vaccine Research and Training Program in India within IVAC. This is being made possible by the generous donation of $5 million by the Pradeep Ghosh and Kumkum Ghosh Foundation. I want to thank them. Their family is here. Dr. Pradeep Ghosh is sitting there in front and Kumkum sitting next to her. And thank you very much. Thank you. Dr. Ghosh has a very long CV, so I'm not going to go through his whole CV, but he obtained a doctorate in economics and engineering from the State University of New York, and he graduated with a leadership studies in Harvard, and he got a diploma in international law from London. He has had a long-standing interest in capacity building in India. He established the International Institute of Innovation and Technology in Calcutta. By the way, I forgot that he has also served as Human Rights Commissioner for Howard County here in Maryland. He does live in Columbia, by the way. He's a neighbor, he and his family. The program, I don't have time to go into what the program plans to do, but we want to learn lessons from West Bengal, where Dr. Ghosh and his wife are from. West Bengal has been one of the most successful states in implementing immunization programs. There are many lessons to be learned, but there are also many issues that we can address in Bengal. Malaria, dengue fever, cholera, all major issues in Bengal. And so we're delighted to have this program established by the generous gift. But also, Dr. Ghosh has had a passion for capacity building and training, which is what we are very proud of at the IVAC, the International Vaccine Access Center. Our training has been primarily through hands-on learning. I think the best way to train people is actually do the job. Go out there and implement and learn it with the people who know how to do it. And also to learn research. Of course, you need the courses, you need the basic training, but then going out there and doing it. And that's what IVAC has done so well. And I want to congratulate everybody here from IVAC. Before we close, I would like to call on Dr. Pradeep Ghosh to say a few words. They told me brief, so please.
I'll be really brief. I'm very honored to be here, and Dr. Santosham, an amazing person, Bill, and everybody over here that are involved with the IVAC program, and that is a very, very critical program for the developing countries. And I've been very fortunate to be working and in a lot of projects. I started this foundation. It's a family foundation. With my wife is here, my daughter and son-in-law is here. Both of them are actually alumni of Johns Hopkins University, received their undergraduate, graduate degrees, PhDs, MBAs, all from Hopkins. Basically, when I met Dr. Santosham, we tried to explore how we can have a partnership with Johns Hopkins University. This is the most premier place. Not only they do research, they also do outreach activities. That's what attracted me. It's not academic, it's more into clinical and more into the field. If you go to India, you'll see we really do not talk about India. I heard about inequity, I heard about advocacy, all kinds of things, problems with political parties and many other factors that are involved. Everywhere you look, it's a public health issue, public health problem. You look at the left, you look at the right, you look at the center, it's all public health. And the climate change is not helping the situation. And I'm just straying away from the vaccination, which is also very important. When we talk about advocacy, it goes both ways, not only advocating with the government, also with the public, because people are not aware of the public health issues. And even if they're aware, they do not do anything. For example, diabetes is a major problem. India is the diabetes capital of the world. And they have no interest or promoting their own health. They do not know what to eat, and they would eat so much sweet that is one of the major problems. And all the heard about child vaccination. There are cultural issues we discussed with Bill and Dr. Santosham about a few weeks ago. And we have to really get out of, see how we can remove these barriers. And so in the last 2 years, I have built a very big infrastructure in the new town of Calcutta. It's a 140 square feet, 140,000 square feet building, probably the best looking building in Calcutta. And Dr. Santosham went there on 3rd of August. And people who do all this IVAC work and other public health work, they are very suspicious of the governments. That's why when he went, I brought some people from the government, very high-ranking government officials and ministers, and they pledged their support. Whatever needs to be done, they will have 100% support. And just to prove that there are government officials, they are very interested in doing that. Especially in the developing countries, the structure of politics and the political areas, they are very different. They start from the rural level, from the panchayat, then district, then block development officer, then it goes to, there is a very complex system. And to penetrate that, you do need the government's help. And these people who are the government officials, they need to be trained in public health. Without their help, nothing is going to change. And so I'm just so happy that we are forming a partnership. And there are so many things that can be done. The opportunities are unlimited. It's not only in West Bengal, it's all over India. And the central government is willing to help, especially Narendra Modi's government and the health ministry, especially the Indian Council of Medical Research. They are out there, whatever we need to do. I think this is an opportunity. We do not let it pass by. And I met with Dean McKenzie, such a wonderful person, and also Provost Sunil Kumar, and a lot of you. And I think our partnership should do well. And I want your cooperation. Of course, through this, Bill Gates Foundation will be joining us, hopefully. We have recruited some 21 scientists. They are working on dengue. In the last 3 months, there were about 80,000 cases of dengue in West Bengal itself, and thousands of people died. But then, if you look at the politicians, they have a tendency to cover it up so that it does not really burden them. And so we have to overcome a lot of things. And just by saying that, I want to thank Mathu again, and of course Dean McKenzie, Bill, and other people. And then I want to thank my wife, my best friend for the last 45 years. And my daughter, Rebecca, and Bevan Philip, my son-in-law, over here. And thank you again.
I would like to call Dean McKenzie for a couple of minutes just to say a few words. Orin, while she's coming up, you'll never be a problem for us as long as the funds keep flowing.
Well, thank you, Mathu, and it was such an incredible afternoon. And I promise I will be brief because I know we have a reception that everybody's looking forward to. But I did want to take this opportunity on behalf of the university and on behalf of the school to thank you so very much, Dr. Ghosh, you and your family, for this incredible gift. It means so much to us. And the gift and the partnership that comes along with the gift, I think, is just terrific. I can't think of a better birthday present. Just wonderful. So thank you, and thank you for your commitment. Thank you for your commitment to IVAC, to the leadership of IVAC, and to the School of Public Health and the university. And we look forward to a very long and productive partnership. Thank you so much.